I have a 37-year-old woman with 1 year history of progressive neck pain and right brachialgia. On examination at that time, he had limited range of motion and pain worsened during flexion and extension. After a good period of conservative treatment, failure was the result of both medications and physiotherapy. And as you can see here, he has two-level discostophide complexes.
Right brachialgia, huh?
Yes.
Did you say?
Then the diagnosis that patient had a 4-5 right posterolateral disc fragment and 5-6 right discostophide complex and inverted cervical lordosis in a 30x years old adult.
Sorry, just before you pass this, he presented with C5 radiculopathy or C6 radiculopathy, or both?
Both.
So like, there is a clear radiculopathy pattern.
And no, neck pain and limitation of movement.
No, I understand that part, but when it comes to radiculopathy, he has C5 or C6 or
Both of them.
Both of them.
Or sometimes you cannot understand which level is it, if there is no sensory or motor measure. And the question is, what to do?
What treatment do you suggest?
Okay.
You need to go back one slide, please, and count for us the cervical spine vertebral body.
What?
Can you count? What level is this? No, go back.
Yeah. Here.
No,
Here it is.
no, go back.
Go back.
Stop. Yeah. Can you count for us? Where is C5? No,
This
go back.
With the other one.
Because this is not a complete picture.
Yeah, but you saw it initially.
Yes, you can
No.
see it here.
The upper vertebrae.
This is 3, 4, 5, 6. It is 4, 5, 5, 6.
But the other one has only one level with the sequestrated fragment down. Go back to the previous one. Yeah, here you don't see two levels. You see only single level and
No, this is
sequestrated
a lateral.
fragment down.
This is a lateral view.
Of which one?
Yes, this is 4-5. 4-5, this
Okay.
can.
Okay.
Yeah, that's
Four,
fine.
5 few.
Fragment in 4, 5 and discostophide in 5, 6. So
Actually, shall we consider doing a fusion because there is some kyphosis or no fusion?
this was one of the questions
Questions.
which was supposed to be answered.
Well, one of the things to look at is in terms of deciding. So again, there's always the question: are they kyphotic as because it's a structural problem, or are they kyphotic for compensation? So you see, in the supine position, they're not particularly kyphotic, and in the X-ray they are. So this is somebody who that kyphosis may be compensatory.
Compensate, yes.
Can you show me the drain X-rays? Yes, this is slight kyphosis here in the air.
It is more or less a straight curve.
Yeah.
Okay, the questions whether to do it single level or double level, to do a dynamic or static fusions.
Okay, let's ask you.
Yeah, I want just to ask another question. Did you do a flexion extension X-ray?
This is a routine.
Or show it to us.
No, not available.
There was not moving on 4-5?
No.
Because if you go to the X-ray, go back to the X-ray once. Sorry, I'm just trying to get the discussion. As if the C4-5 is fused in.
No, C3-4 is the anterior view.
C3-4 has fused.
C2, C3, C4, yes. Okay.
4-5 is not.
Then the selected treatment was to do a static fusion with cage at L4-5 and to do a dynamic fusion at C5-6 with dynamic cervical implant.
We must call it dynamic fixation, not fusion.
Dynamic fixation, yes, it is.
Yeah.
And that was the post-operative films, and the patient did well for a while. Then started to have this progressive severe axial neck pain, spasm, and limitation of movement. Despite the first pictures were mostly doing well and the end plate was intact and everything was good, then it started to show progressive
good case
subsidence unfortunately in the dynamic level, and the patient, I tried with him every possible conservation available, and with failure, severe progressive axial pain and limitation of movement. What would you like to do in such a case?
It is more difficult now.
How bad is the pain?
What?
How bad is the
It
pain?
is limiting his natural life. Severe axial pain, not tolerated, he cannot move his neck.
So, see, if you take a scenario where you have such a situation on the X-rays and the patient doesn't have pain, you basically presume that ultimately, it subsides and the end plates are going to come close to each other and it just fuse.
If you look at this early post-operative flexion extension views, everything was nice.
No, what I mean to say is that later on, at this point, if the patient did not have pain, you would just allow that to fuse, because there is some anterior, fusion. The end plates are coming close to one another. Ultimately, it will fuse. At this point, you can ask the patient if he has some patience, he can still wait. Otherwise,
I waited for a long time.
So you remove it and fuse it.
I waited for a long time for it to fuse.
So then
or to stop subsiding. But the pain was progressive.
Can we have them?
You have two options. You do an anterior fusion or do a posterior fusion. If you do an anterior fusion, you have to remove the implant and
what would you like to do?
If you do any injection, that is a problem.
Injection?
Yes.
This is axial. Axial.
You can try it, and you can find where is the level. If you after the operation, if we against any problem.
What type of an injection would you
For example,
consider?
transforaminal injection
For what?
for cervical, which level?
Actually, it is axial pain.
Mechanical pain.
Foraminal injection will not help.
Injection, I will do or neural therapy.
Facet injection.
Neural therapy, and you will find where is the source of the pain firstly. After that, for example, if we do the operations, there will be no problem like this.
Okay. I would suggest making a fusion graft, removing it, and then plating.
C5.
Without plating, it is not possible.
5-6 is 5-6 is gap.
Yes.
You can see that on the X-ray.
Yes. Why? This is a very good question. Why we choose the selection to be static on L4-5 and dynamic on L5-6 and not the reverse?
Okay. There is no good answer of that.
Can I answer it? My own point of view.
Yeah.
My own point of view was that if we do a double level static fusions, L4-5, L5S1, then we will leave him for another 30 years with a single moving level at 6-7 between junctional cervical dorsal zone and a statically infused level above. It will be a very high risk of very rapid deterioration.
Because of adjacent level disease,
Yes, this
you are scared of adjacent level disease. You wanted to make
yes.
a
The
hybrid surgery.
The problem there, though, is biomechanically, a motion-sparing device at the top of a long fusion will have much better survival than a motion-sparing device at the bottom of a long fusion. And because 3-4 was spontaneously fused and you were fusing 4-5, you're putting tremendous loads on your dynamic device. You might actually have been better to do it the other way around. To have your static device at 5-6 and your dynamic at 4-5.
Retrospectively, you are absolutely right, and maybe it is much better to put the two of them dynamic.
Yeah. Could
I asked this question because of this, because the C3 and C4 is fusion already. If you fuse the C4 and C5, it means that you fuse 3 vertebral column and you put the dynamic cage in the bottom, and this is the result. That's why I asked this. If you change this, switch it,
maybe not.
We don't know, but
Yes.
just
Then it was, shall I continue or we want to?
Yeah, please. Yeah.
Professor Siri, may I
Yeah.
expand a little bit the discussion? Can we see the early post-op dynamic X-rays?
Early post-operative?
Yeah, whether there is a really motion preserving or not.
Yes. I have many of these dynamic cervical implants, and many of them are keeping motion inflection.
There is motion there because you see the interspinous distance is opening and closing.
I didn't feel like that.
No, it is.
In extension,
Where's the
Pointer.
extension C5
laser?
is touching C6.
Give it
And
that.
inflection
I know
is
that.
3 or 4.
Okay, I see now. Okay, sorry.
Yes, this space. Sorry. Yes, this space is.
Larger than in the
Yes, this is larger. This is
narrower.
narrower. So it is moving.
Okay.
It's a dynamic. Yeah, right. Yeah.
The first this prosthesis had a lot of testing for that indication, and there was a lot of discussion and light brain disc prosthesis and the following. And then after this prosthesis are accepted, we saw that kind of devices, but they're not proven or tested. We see a lot of domestic disc prosthesis also. They are similar but not the same, so they are not tested. That device may allow some flexion extension, but no rotation. For example, they have completely different biomechanical characteristics.
Yes.
So
it allows for flexion and extension, but not
so that
lateral
it
bending.
may be good or bad. We don't know. They are not
But frankly speaking, this is the only and one case of subsidence I have met.
Yeah, it may work. I am not against that particular, but I say that we saw a lot of similar products copying the previous one, but they are not tested. They are not have the same testing than before. In that case, I would prefer to make a fusion, but posteriorly, because of the anterior side is already opened and may have some problems. If we need some fusion, we can do it posteriorly.
Great. This was one of our options, really. And that was.
I would do anterior as well.
That was the MRI. And the question was to go anterior or posterior.
Anterior.
I would want to go anteriorly because I want to get the lordosis back and the loss when it's subsided.
Yeah.
Okay, but what will you do anteriorly?
I would remove the implant and I would use Because
to remove the implant, you should do partial corrective.
Yes,
Total
No,
corrective.
it is
Not partial.
recently I did similar case with the similar cage,
Not partial.
which was implanted in Germany. It's quite easy.
And what I would
No, it is inside the vertebral body. The lesion.
But what
No,
I
you
would
can
use
bury
in
it
my
out.
graft, because
You have
I
to
have
remove,
easy access to
C5.
it, is I would use fibular allograft because then I can fashion it to any shape or size defect that I want. So whatever I get when I pull that prosthesis out, I shape a piece of fibular allograft till it machines and fits in. And then I would probably go posteriorly because that's a long construct. And so I would probably do this front and back.
I used a vertebral body distraction. It was very easily removed. It was after 2 years of primary insertion of a disc prosthesis, the case I'm telling you, and the patient has got worsened because she had primarily a spondylotic myelopathy, and for a spondylotic myelopathy patient, placing a dynamic fixation is a contraindication.
Yes. That's
Yeah,
right.
but it may happen. But this time it is as instability only. And with axial pain, yeah, right.
So,
You did posterior.
this was what we did.
You got very good correction, so you were able to accomplish what I would have been aiming for with the front and back. Did you do any facet resection, or you just took what you got?
No, we just put the screws and did some compression on the rods, very little compression.
Which gives you an idea of how unstable this actually was. That you essentially got her to neutral and maybe even slightly lordotic without going anteriorly. And anteriorly, as soon as you get stability, that's just going to fill in with bone.
Patient got reduction of pain and discharged in the first post-operative day. And after 3 months after the second surgery, neck pain now is much better. In this particular case, we try to make facet curettage and bone facet fusion, and we put on-lay grafts also to try to make it fusion rather than just an instrumentation.
If you go back and CT her 6 months out, she will have fused anteriorly.
Yes.
What is your follow-up?
This is the follow-up. It's 3 months. It is now 3 months.
One that would